Hello, this is Garret Choby, and today we will be discussing a case of a left-sided inverted papilloma with a primary attachment point in the left posterior ethmoid cavity. As you can see on the patient's preoperative imaging studies, there's a left-sided sinonasal tumor taking up the majority of the nasal cavity, and on this upcoming still image, you can notice that there is an area of thick hyperostotic bone in the posterior ethmoid cavity in the circle there that denotes the likely primary attachment point of this tumor right along the skull base in the high left ethmoid cavity. And then here's the patient's corresponding axial CT scan, once again demonstrating the left-sided sinonasal tumor. At the outset of the case, you'll see that we are identifying the tumor here. It has quite a papillomatous attachment filling the majority of the left-sided nasal cavity. And what I like to do at the outset of these tumor dissections is to go ahead and palpate around the tumor with a caudal or a freer elevator to determine if there are any low hanging attachment points of the tumor low in the nasal cavity. In this case, what you can see is that the tumor is not attached to the nasal floor or along the nasal septum, but the bulk of the tumor, as you can see here, is coming medial to the middle turbinate in an area called the olfactory cleft. Although this patient has had a previous biopsy in clinic demonstrating inverting papilloma, I do like to remove a large portion of the free-hanging tumor at the outset of the case to confirm pathologic diagnosis on frozen section, as well as to clear the nasopharynx to allow for egress of blood during the case to allow better visualization throughout the remaining portion of the tumor dissection. After that initial low-hanging tumor is removed from the nasal cavity, we'll then use a microdebrider such as this to debulk the tumor in the area where it has no attachments along the mucosa. And as you can see here, we're dissecting up the tumor from the low part of the nasal cavity, again medial to the middle turbinate towards the olfactory cleft, carefully assessing for any mucosal attachments as we go. What you can see here is the tumor, although it's present here in the olfactory cleft, has no attachments high along the cribriform or the olfactory fila, but instead you'll notice is actually protruding from the posterior ethmoid cavity at the junction between the basal lamella of the middle turbinate and the superior turbinate, and then coming into the nose medial to the middle turbinate. In light of this, we debulk the tumor in that particular area, and then we'll proceed with some routine sinus surgery on the left side in order to facilitate access to the posterior ethmoid cavity. Here we are completing the initial portion of a maxillary enterostomy. This is a pediatric terrier backbiter performing a retrograde uncinectomy on the left side. And then we'll open and allow access to the maxillary sinus as we move posteriorly with our dissection. After the uncinate has been removed, we've got a 30-degree scope on identifying the natural os of the maxillary sinus here in its classic parasagittal position. We'll dilate that posteriorly and then widely open this maxillary sinus further back with a through-cutting instrument, as you can see here. The bulk of the tumor is, of course, not in this particular area, but what this allows us to do is to have full access as we dissect posteriorly and allow a thorough working space for our instrumentation. Then here we are identifying the ethmoid bulla, and we'll simply enter into the face of the bulla here with a maxillary ball probe, and then remove this with Carlson rongeur, with an up to Carlson, as well as a microdebrider. And the most important part with our ethmoid bulla dissection is not simply removing it, but also identifying the basal lamella just posterior to it, as well as the lamina papricia on the lateral aspect. As we continue to dissect through this area, moving the last bit of the medial part of the ethmoid bulla, you can see the basal lamella just behind us, as well as that lamina again lateral to us. Then we'll enter in through the basal lamella in an inferior and medial fashion in order to access the posterior ethmoid cavity and identify the superior turbinate just on the other side of this partition. As we dissect through this area, it's important that we again delineate the tumor, and we're going to remove the basal lamella to facilitate our access posteriorly, but keeping the tumor intact so we can carefully dissect that and further identify its higher attachment points. This is a microdebrider, again removing the basal lamella superiorly and then laterally out towards the orbit, then coming back in with an up to Carlson to further facilitate a higher dissection here along the basal lamella. And what you'll begin to see is the tumor again just behind this area of the basal lamella, again in the ethmoid cavity posteriorly. This is now the superior turbinate. You can see the papilloma nearing its attachment point along the junction of the superior turbinate and ethmoid skull base. Here we are debulking a little bit of the low-hanging papilloma as we continue to work higher in this area near the junction of the superior turbinate and a posterior ethmoid partition. We are then improving our access here laterally, further dissecting out and skeletonizing the orbit and working up higher towards the ethmoid skull base here as well, as we increase our access to the last bit of the tumor dissection. This is the last bit of the remaining tumor, as you can see here, nearing its bony partition attachment along the skull base. Here we are taking down a bit of that bone and then dissecting again with a microvertebrator. And as you approach the attachment point of the tumor, what you'll notice is the bone becomes more firm. So here's that final hyperostotic bony attachment of the ethmoid partition on the skull base. And we're removing that here with an up-to Carlson to fully remove that involved bone where the primary attachment point is. This is then allowing skeletonization of the ethmoid skull base here in the last bit of that bony partition. Here we are using a caudal elevator to remove the mucosa of the ethmoid skull base on either side of that hyperostotic bony partition. And we will also send this for frozen section pathology to ensure that there is no additional mucosal involvement near the hyperostotic bony attachment. There's the posterior ethmoid artery just behind us, and again, the lamina papricia lateral to us, where we are dissecting along that posterior ethmoid skull base. And then in order to facilitate access and long-term surveillance, here we are opening up the sphenoid sinus widely. You can see in this case, there's a bit of a node cell or a posterior ethmoid cell pneumatized just over the face of the sphenoid, but here we are through the natural os of the sphenoid sinus, and then opening up that widely, laterally and superiorly up to the planum for long-term surveillance. And then again, for long-term surveillance, I also like to open up the remaining portion of the sinuses on this side, including the frontal sinuses you can see here, in order to allow us full access to the area postoperatively. I find that when you don't fully dissect out the entirety of the sinuses on the ipsilateral side, you can easily be mistaken by some mucosal edema or other debris following surgery and worrying that's an inverting papilloma recurrence later on. In this case, the patient has a rather large supraauger frontal cell. So here we are working through the natural outflow tract of the frontal sinus just posterior to that. And here the side-to-side frontal through-cutting instrument to take down that partition between the supraauger frontal cell and the natural outflow tract of the frontal sinus. And then here with a frontal Hoseman punch coming in and removing the remaining portion of that supraauger frontal cell partition to fully access and open up that frontal sinus. And now visualizing with a 30-degree scope into the frontal sinus itself on the posterior table, as you can see there. And then just confirming our location along the orbit and identifying some additional suprabular partitions in this area here, which we'll skeletonize to fully open up the area along the skull base as it transitions from the anterior ethmoid skull base into the posterior table of the frontal sinus. After that's complete, you can see we have some postoperative image of the patient 4 months after surgery and then 1 year following surgery, demonstrating a well-healed cavity with no evidence of inverting papilloma recurrence. Key points when endoscopically resecting inverting papillomas are the following. It's very important to identify the primary attachment points of the tumor and to remove these attachment points fully. When there's hyperostotic bony partitions where it's attached to, as commonly occurs in the maxillary sinus, these frequently need to be drilled down, or when they're more simple ethmoid partitions, they simply need to be removed in its entirety. I do like to send margins, mucosal margins of the tumor for pathology to ensure there's no additional mucosal attachments in these areas. It's also important to have the entirety of the tumor assessed with pathology, as roughly 10% of these can have some malignant transformation on final pathology. And then lastly, long-term follow-up is very important, as there are historical high rates of local recurrence of these benign but locally aggressive tumors.